Good evening, everyone. So we are waiting for a few of the presenters to join in. We are going to be starting in a few minutes. Just a few things that you need to be aware of. All these CMEs are being live streamed to YouTube, so please feel free to share it with your comments. Also, the other thing that you need to know is that in case you have any questions, please post them in the chat. And in case you want to ask directly, please feel free to raise your hand and unmute yourself, and then you'll be allowed to ask a question. So today, as you can see, we are going to be talking about sepsis and microbiology. So we shall quickly go into the introductions for the speakers of the day. Dr. Rasmus will be joining us as soon as possible. So allow me to share some of the slides that have been prepared specifically for this talk. Okay, so I hope you can all see this. In case you can't, you can let me know. So basically, the discussion today is going to rotate around sepsis and focusing on microbiology, and we shall be looking at drug-resistant bugs. We shall also be looking at morbidity and mortality, as well as cost of care, therapeutic options, and potential areas of research that will be included in the talk that we are going to have today. So basically, we hope that at the end of this talk, you will be able to consider the nature of pathogenic microbes that you're most likely going to meet when you're handling patients with sepsis or septic shock, and then the diagnosis of microbial diseases. How do we do that? And then human microbiome and sepsis. Is there an interplay? Do organisms actually protect us from getting sepsis and septic shock? And if they do, how do they do that? And how do they interact with the immune system to protect us from the extremes of organ dysfunction? And then we shall talk about microbial pathogenesis and resistance. So in this particular talk, we are going to listen to Samuel Olowo, who is an ICU nurse at Mulago National Referral Hospital, who did research in co-infections among COVID-19 patients in Ugandan intensive care units. So I will, at this point, talk about the other speakers. That is Fred Nseko, who is a resident in year 2 in anesthesia and critical care at Makerere University, who will be talking about basic microbiology and diagnostic processes in the ICU. And then we shall hear from Peter Waswa, who is a fellow in critical care medicine with the SCALE critical care program. And we'll be talking about the microbiome and sepsis. And finally, we shall listen to Paul Katongole. These are all doctors, by the way, except Samuel Olowo. And Dr. Paul Katongole is a microbiologist with extensive experience in antimicrobial resistance, infection prevention and control. And he will be talking about exactly that, multi-drug resistance and infection prevention and control. So as the speakers go through this, we shall be listening and trying to share with you some of the poll questions related to the talks that we'll be giving. Please feel free to respond to those poll questions, and we shall close the polls when 50% of the audience has responded. So to just get us started, let us jump into the first poll and see what the audience thinks regarding sepsis and microbiology. So in a minute here, I'm going to be sharing the first poll. And here it is. Please feel free to answer this poll. I hope if you can't see it, then please go to your phone where you see the three dots that say more, and tap that, and then it should bring an option for you to handle the polls and quizzes that have been shared. So please respond to the current poll, and then we shall close it. In the meantime, I will request Samuel Olowo to share his slides so that we can, as soon as the polling is done, we can start off with the presentation. There are no responses to the poll question yet. If there are any challenges, please feel free to go to your three dots. If you're using your phone, go to the three dots at the right side of your screen and tap them, and then that will open up a menu that has polls and quizzes. If you don't see the polls, please just let me. Is anyone seeing the polls?
Nope.
Okay, let me end the poll and then share it again. Just a second. Okay, I'm relaunching the poll. Okay, the poll has been relaunched. Please let me, if you can see it, please respond. The question is about viruses are not recognized cause of sepsis. And you have three options. All right. Okay, for some reason I do not see the responses, although people are responding to them. Hopefully they will show up when I choose to share the responses. So I will give that about a minute and then I will close the poll. All right, thank you everyone who is responding to the polls. Let's keep fingers crossed that we shall be able to see them. Okay, so I will close the poll now and then see if there are results to be shared. Okay, I think today the machine has decided to fail and not show us the polls. So what we'll do is to proceed into the presentation and then we shall relaunch the polls at the end. I think that would be the more appropriate thing to do. Sorry about that glitch. It's sometimes expected with these things. All right, so Samuel, please proceed with the presentation and then we shall try and relaunch the poll again after we have it fixed. Thank you.
Thank you very much, Doctor. Good evening, colleagues. I'm called Samuel Olowo, a registered nurse at Mulago Hospital, but currently I'm pursuing my Master's in Critical Care Nursing from Mbarara University of Science and Technology. So I'm glad to be in this platform, and I thank Dr. Okello for inviting me to share this research with the team. So this was a research among COVID-19 patients. Specifically, we are focusing on the co-infections among COVID patients. It was quite a multidisciplinary research because we have nurses like me, John, Florence, Martha. These are all ICU nurses. And then we have doctors, ICU doctors, Dr. Sandy, Dr. Jane, and then Dr. Kello. Then we also have like Sister Lydia Senyonga is the head of department of nursing at Busitema University, Faculty of Health Sciences. And then also we had a microbiologist, that's Dr. Jacob Eramoy Stanley, head of department at Busitema University, Faculty of Health Sciences. Slides are not moving. Why? My slides are failing, but let's sort it out. Okay. So the background of our study, COVID-19, from our experiences, what we observed is that it has significantly strained the global healthcare systems. And it seemed like at the peak of the pandemics in most countries, the systems appeared to be inadequate. And as COVID-19 is new, it's a bit new, and one of the concerns that scientists are focusing on right now is what could be the long-term impact of the SARS-CoV virus, which was the COVID-19, on antimicrobial resistance. The reason is that during the management of COVID patients, there was anticipation, or there is anticipation, that these patients could be having co-infections in addition to the COVID-19. And health workers, health workers and doctors who are involved in the care of these patients were informed, or they were encouraged to prescribe broad spectrum antibiotics empirically to these patients in an attempt to mitigate the possible co-infections that could be co-occurring with the COVID-19. According to international literatures, it is postulated that by the year 2050, antimicrobial resistance will account for over 10 million deaths, and also that the treatment cost is estimated to be as high as 100 US trillions. This is quite a lot. However, in our country, which is a developing country, Uganda, where we have inadequate data to inform decision-making in the management of empirical management of co-infections among COVID-19 patients. So basing on this background, we decided to carry out a study on the co-infection and their antimicrobial susceptibility pattern among COVID-19 patients in Ugandan intensive care units. The problem that guided our study is that the pandemic of COVID-19 has led to upsurge of critically ill patients. And in most cases, these patients, especially those ones with the severe and critical forms of the infections, tend to require intensive care for advanced life support, specifically oxygenation. Studies have found that bacteria and fungi have been, most cases, are isolated as agents for responsible for co-infection among COVID-19 patients in ICUs around the world. And these co-infections have been associated with worse outcomes. One of them is mortality, increased length of stay, and also development of super infections, which are resistant, they are refractory to the conventional antibiotics used in the non-COVID patients. So our methods, this was a multi-centered study, cross-sectional. We did a retrospective survey in 3 intensive care units, that is Mulago National Referral, UMC Victoria, and TMR International Hospital. We reviewed records of 216 hospitalized patients, ICU, for COVID-19, and we employed purposive sampling. During the process, we designed a data abstraction tool after a comprehensive literature search that we use as a tool for data collection. So after we did the cleaning and the data was entered in Epidata. And then later on, analysis was done using Stata version 17. This study was approved by Mulago Hospital Research and Ethics Committee.
Apologies, I think we have lost Samuel there. Samuel? Hello? Samuel, are you able to hear us? Okay, so it seems we have lost Samuel. So in the meantime, as Samuel gets back on, I will share the results of the poll from the previous poll. And it seems the majority of the audience seems to agree, rather to say it's false. Viruses are not recognized as cause of sepsis, and that is false. And I think we shall have that discussion after Samuel's presentation, and then as we wait for Samuel again to return, we shall launch another poll just to make sure that we don't spend so much time with the other thing that we have to do. So I'm going to launch the next poll. Okay, just a second. Okay, the second poll has been launched. Please feel free to respond. Again, it's about sepsis and microbiology. And it's asking, septic shock is never seen with malaria. Is it true or is it false? Or are you not sure? Okay, we shall be closing this poll in a few seconds. Okay, so these are the results. I hope you are able to see them on your side. So again, excuse me, 92% of the audience said false, and a very small percentage said true. So indeed, septic shock can be seen with malaria. All right, and then we shall go into the third poll, and as we wait for Samuel to come back online. Okay, here is the third poll regarding sepsis and microbiology. The most common cause of septic shock in the ICU are multi-drug resistant bacteria. Is it true, is it false, or are you not sure? We shall close the poll when we hit 50%. All right, so I'll end the poll here, and then I'll share the results, which I hope you can all see. So from this, the most common cause of septic shock in the ICU are multi-drug resistant bacteria. 53% of the audience say that is true, where 38% say that is false, and a small percentage says they're not sure. And I think these are questions that we hope that will be answered throughout the talk that we're going to have today. So I'll check again if Samuel is on, and then we shall proceed with this presentation. Just hold on a minute. All right, Samuel, please proceed from where you ended. We are glad to have you back. Samuel, can you hear us?
Hello.
Yes, Samuel, we can hear you. Please proceed.
Hello.
Hello, Samuel. Samuel, we can hear you. Please proceed, and if you could wind up your presentation in 10 minutes would be great.
Hello.
Yes, Samuel, we can hear you. Please proceed.
Sorry, my computer went off. I'd not plugged it in power. I'm sorry for that.
All right, it's all right. Please proceed, and
Okay.
we have given you 10 minutes to go through the presentation. Thank you.
It's okay.
All right.
So we also obtained administrative clearance from the directors of the 2 hospitals, of the 3 hospitals. We ensured the participant anonymity. We had to use, we allocated them unique numbers so that nobody could identify them. So on our results, a total of 216 records were considered for the final analysis, and the majority of these, the participants were male. Mean age was 54.54 years, and most of them were from the private facility. So concerning the co-infections, the prevalence of co-infections was 51.39%, and respiratory tract infection was the most prevalent. Among the organisms, Staph aureus, Cytobacter friendly, Pseudomonas aeruginosa, and Klebsiella pneumoniae were the most frequently isolated bacterial species among these patients. Also, concerning drug resistance, we had a high prevalence of multi-drug resistant bacterial species, which was 75.95%. Among these multi-drug resistant species organisms, around 8.75% were extended spectrum beta-lactamase producers. However, some of these organisms were susceptible to augmentin, amikacin, and trimethoprim. Concerning the antibiotics, augmentin and ceftriaxone, they had the highest and lowest. Augmentin had the highest, ceftriaxone had the lowest overall susceptibility. And the fungal organisms were accounted for 27.93%. However, these fungal species, Candida albicans, had good overall susceptibility to our antifungal agents that we use in our settings. So this graph simply showing us the overall susceptibility. The blue represent the number of organisms, the isolates that were susceptible. The red, they are the total number, and the other color shows the percentage of the organisms susceptible. So if we follow this graph briefly, I realize that augmentin had the highest, like I said previously, and this was followed by tetracycline, chlorphenicol, imipenem, and amikacin. And then ceftriaxone here showed the lowest. However, you realize that there are some of them appeared to be high, yet because we considered only, because this was a record review, we considered only those antibiotics that had at least 4 organisms tested for susceptibility. So these were the significant ones, the ones where we discussed. So this study found a higher prevalence of co-infections of 51.93% among COVID-19 patients in Uganda intensive care units. However, this higher prevalences among COVID-19 ICU patients have been documented in other studies in China, where 58.3% of the bacterial respiratory pathogens were isolated among COVID-19 patients, and Belgium, where a 40.6% prevalence of co-infections was found among intensive care unit COVID-19 patients. So in conclusion, this study found a high prevalence of co-infections, bacterial and fungal, and respiratory tract infection was the most prevalent co-infection among COVID-19 patients. We realized an overwhelming burden of multi-drug resistant infections and also some extended spectrum resistant organisms among COVID-19 patients admitted in Ugandan ICUs. So from all this, we recommend that there is a need to establish stronger policy measures in regards to antibiotic stewardship, antimicrobial surveillance, and infection control. This will help us to inform an empirical antibiotic therapy, and consequently help us to mitigate the spread of mild drug-resistant bacteria and antibiotic drug resistance among COVID-19 patients in Uganda. Thank you very much for your attention.
Excellent presentation, Samuel. Thank you very much for sharing with us the results of your study. And congratulations to you and your team on such important work that most of us may not have had privilege to actually get to know. So there are a couple of questions in the chat room, and I will read them out to you for your response, and hopefully in the next 5 to 10 minutes we should conclude on the questions. So the first question is, what brand of ceftriaxone are we talking about? Was that information captured in your study?
That information wasn't captured in our study, and we acknowledge that's a limitation.
Right.
We did capture because we are doing records review.
Okay.
Yes.
All right. And then which particular samples were tested, and at which point during admission were those samples taken?
The samples, we considered samples taken if you at admission, meaning either a day or 2 from admission. And the samples were used majorly urine, urine samples, tracheoaspirate in case the patient was intubated on arrival, blood, and the pus swab.
All right.
Okay.
And those were, you said those were taken within the 48 hours, yes?
Yeah, they were taken within the at admission. Okay, 48 hours in general.
All right. So someone else has asked, is there a similar study done in non-COVID patients that you came across during your literature review?
Yes, a similar study was done by Kwezira. That was around 2016 in Mulago National Viral ICU and the IHK. There's a similar study. Yes.
All right. And then the other question, I think this one is from me. So do you have any information on how long these patients had been in the hospital prior to their admission to the ICU, at which point these samples were taken?
We don't have that information because we couldn't access some of the files in the private were limited to only what we needed. In other words, we anticipated resistance in accessing the patient's files, so we only rotated only on the organisms and the time at which point the samples were taken. Like in the TMR and the Victoria, they have their electronic database that they record these samples. So we majorly use the electronic data from the private hospitals. So we couldn't get that information because of some limitations due to some reason that we can't tell.
Okay. So perhaps the other question that would be asked is, so at which point did we have this information as the critical care community, and was it used to guide on some of the antibiotic prescription during the COVID pandemic? So perhaps maybe let me ask, was this from the first wave or the second wave? And did we have this information to guide on antimicrobial therapy in terms of management of COVID patients who are coming to the ICU with co-infections or potential co-infections? Two questions in one, sorry.
Yes, first of all, this study, we have just released the results.
All right.
In other words, somehow it wasn't used at that time. It wasn't used. Yes, because the results are just out. We have been collecting data all along, and we have just released the results, and we are glad that the first place we are sharing this presentation. Yes.
Dr. Cornelius and Mr. Lowe, just a quick one. Dr. Erasmus here. Cornelius, I didn't get your question very clearly. Are you asking if the results of this study were used to guide decision-making around COVID time, or are you asking if the findings of these cultures and sensitivity profiles were used by the clinical teams to guide care? Maybe just for clarity.
Yeah, so it's more or less both, but I was curious to whether the results of this study provided any guidance, or rather when the results were released, to see if they provided any guidance. But I think he has answered that, since it came after the COVID pandemic. And so, of course, that would lead me into the question on whether there was any change in antimicrobial therapies during the COVID pandemic in the ICUs that these samples were taken off in terms of prescription. Of course, this was not captured in your study, but from your impression when you collected this data, was there any impression that perhaps these results were, from each of the ICUs, these results were used to provide guidance to which antimicrobial therapies were used during that time, which is what Dr. Erasmus is actually trying to clarify on.
Yeah, so these results were not used.
They were not used, okay.
Yes.
And the other question was whether this was the first wave or second wave. Or
okay. It was, since it was record review and we expected numbers, so we considered first, second wave.
All of them, okay.
All of them, because of sample size.
All right,
Yeah.
Dr. Erasmus, you had a comment to make.
Yeah, no, again, I guess just the tune of the question is what was confusing. When Mr. Law says these results were not used, definitely, I guess the study here focused more on the laboratory findings and the isolates plus their sensitivity profile. So it was more of a review of the data of laboratory studies. So the clinical aspects and the clinical decision-making and application of these was not assessed. So we like to believe definitely that the clinicians used this data for clinical decision-making. However, like Mr. Law says, the data from the study here definitely has not been used as the COVID crisis passed us now. But the information was available to the clinicians, and unfortunately not assess whether they used that data to actually make decisions on antibiotic prescription.
Thank you very much. I think these are very interesting results, especially from our setting. Most of the studies, I think, during the time of the COVID pandemic seem to indicate, at least at the time when patients were coming into the COVID wards with symptoms suggestive of severe respiratory failure, most of them did not indicate that these patients had a co-infection with bacteria. But the studies seem to indicate that patients who are staying in the ICU for a longer period were more likely to have a bacterial co-infection. And of course, that also increased the mortality among those patients. So that is why I was curious to how long, if there's any information on how long these patients had been in the hospitals prior to ICU admission, because as we shall see later on, that in itself predisposes patients to having co-infections. But I think, again, this is very interesting work, and I'm really curious to read the manuscript when you finally publish it. Of course, the reviewers are going to be quite interested and get ready to answer a couple of questions more than what we have raised. So let's move on into the next presentation, and that will be from the next presenter, who I'm going to introduce now. Just a second. And the next presenter here is called Dr. Fred Nsereko. And Dr. Fred Nsereko is I think is now year 3 resident in anesthesia and critical care. And he's going to talk about basic microbiology and diagnostic processes in the intensive care unit. So while Fred does that, we are going to go, while he shares his slides, we are going to go into a poll question and try to get ourselves acquainted with some of the things that Fred may talk about. I think if you don't see the poll questions via your phone, please make sure that you tap the 3 dots on the lower side of your phone, and it will take you to the poll question. So I'm going to launch the first poll question, and then we can respond. Once we hit 50%, then we shall close the poll. So here is the poll question. There is no gold standard test to diagnose sepsis. True or false, or I'm not sure. Please feel free to respond. Dr. Erasmus, please get ready to have some responses to the first poll questions as we go through this presentation. We shall have responses to the poll questions from the start up to the diagnostic. Okay, I think we are beyond 50%, so allow me to close the poll now and then share the results. So 77% of the audience says it's true, there's no gold standard to diagnose sepsis. So we shall launch the second poll regarding okay, so here is the second poll. So approximately 1 in 3 patients initially diagnosed to have sepsis have non-infectious conditions. Is it true? Is it false? Or I'm not sure. Okay, we're almost at 50%. So we have over 50% of the audience now. So I will close the poll and share the results. So 52% of the audience says it's true, while 29% says it's false. Again, we shall talk about the results of each of these poll questions later. So I'll stop sharing that, and then I'll share the final poll on diagnosis. Fred, feel free to answer these poll questions as you go along in your presentation. Okay, so the final poll question is here. So which statement is true regarding results of blood cultures? Which of the following statements is true regarding the results of blood cultures? Feel free to say, I'm not sure. That's also acceptable. We are all here to learn. Finally, we have someone who said, I'm not sure. Okay, so since we are above 50% of the audience, I'll end the poll now and then share the results. So we have the second option being the most selected, with 60% of the audience saying best drawn at the onset of rigors in a febrile patient. All right, so I'll end that poll here, and then just allow me to see if there is any other poll question left. I think that was our final. Okay, there's one more poll question, sorry. And here it is. This is the final poll question on diagnosis. So according to the latest surviving sepsis campaign guidelines, microbiology cultures should be drawn before antimicrobial therapy unless a delay of more than 45 minutes is anticipated. Do you agree? Do you disagree? Are you not sure? Okay, we're at 42%, so we're almost 50% of the audience. Then we shall close the poll. All right, we have hit 50%, so I will close the poll now. So the audience agrees 77% that we should not delay antimicrobial therapy if microbiological cultures will be delaying the administration of antibiotics for more than 45 minutes. All right, so I will end the polling now and then hand over to Dr. Fred Nsereko to start his presentation. Over to you, Dr. Fred.
Good evening, Dr. Cornelius. Can you hear me?
Yes, we can hear you.
All right. So I'm Dr. Fred Nsereko, a resident of anesthesia and critical care from Makerere University. And we're going to touch upon the basic microbiology and diagnostic processes of the ICU infections. In introducing the topic, infectious diseases are caused by a number of pathogenic microorganisms that may be classified as viruses, bacteria, parasites, or fungi. So sepsis can be caused by any of these things. It's important to identify the potential microorganism causing sepsis in order for you to initiate appropriate treatment. Unfortunately, diagnosing the etiology of these microorganisms requires us to do cultures. And this is a very archaic technique that has a time lag between it, usually requiring 3 to 5 days. So the delay is always greater than 48 hours, whereas we might not have, the patient may not have as much time. However, there are newer systems that significantly shorten this time frame. We will see some of the new technology that is able to do this. As an adjunct, at the point when patients are coming in, you can use some biomarkers that lately are gaining popularity, like the procalcitonin, the C-reactive protein. Your total white cell counts are also part of this. They can give you a clue as regards sepsis. In diagnosing infections, we use a combination of clinical findings and a couple of diagnostic tests. Direct observation of potential sources of infection is also acceptable, especially if you've seen it at surgery or at endoscopy, or by eyeballing. If it is at the skin surface, you can see infection. Infection can be categorized as hospital-acquired if there is no evidence that it was present or incubating at the time of admission. It is categorized as community-acquired if it is contracted outside of the hospital and diagnosed within 48 hours of admission without the patient having had an encounter at a health facility. This distinction is important because we have bugs or germs that we expect to find in community-acquired infections, and those we do not expect to find. However, often there may be cases of certain bugs we expect from the ICU showing up in the community, especially since now lower level centers of care are actually using ICU antibiotics. Specimens that we can draw in order to be able to see the etiology of infection include blood, urine, CSF, sputum. We can swab wounds, we can take stool samples, any bodily discharge, among others. So the microorganisms we're talking about, most of the microorganisms you see in the ICU are going to be bacterial in nature. Here is a list that attempts to show you a spectrum of microorganisms you find specifically in the ICU. I did not do a similar table for community-acquired infections, but there are those that we expect in the community and then those we expect in the ICU. And in people who are hospitalized, they're usually a bit more vulnerable than those in the community, so they're likely to fall more sick from microorganisms that we ideally live with, such as the staph epidermidis that are found on the skin normally. And things like lactobacilli that are normally found in the vagina and don't cause issues, but when people are very sick, these defenses fall and they can indeed become pathogenic. There's some terms that are important to familiarize with because, like I said, certain bugs we expect in the ICU and those we expect in the community. So these terms, multi-drug resistant, we have these often in the ICU because of the prolonged use of antibiotics, and almost always these patients are covered with antibiotics. So we have multi-drug resistant organisms that are described by their ability to resist susceptibility to more than one antibiotic. Then we have, that is at the start of the spectrum. Midway the spectrum, we have the extensive drug-resistant organisms that have no susceptibility to at least no susceptibility to at least most of the agents, but in some classes there might be some agents to which they succumb in one or two classes. These types of bugs are also emerging in the ICU. We'll see a study that some people did here that categorizes for us some of these. And often the issue here is you'll find the minimum concentrations that are required to kill off these bugs are actually in a toxic range when you're doing the therapeutic drug monitoring, which we don't often do, but you will need very high doses or you need several combinations of drugs, and this increase the risk to the patients in the ICU. We have pan-drug resistant bugs, which are bugs that are not susceptible to any clinically available drug. And these bear a very high mortality which in some estimates approximates 50%. It's like a coin toss that you succumb to this or you survive it. But the mortality is variable on different studies. It's also very hard to say a bug is pan-drug resistant because our labs choose which antibiotics they're going to test for. So it's practically not possible to test for all the possible antibiotics in the world. So pan-drug resistance would mean whatever is locally available doesn't work, but there could be other options that work, maybe not locally available to you. The common sites of infection, there was a study, the EPIC study, that was performed on 14,000 adult patients across ICUs in the UK. The common sites of infection were the lung, which comprised 64% of cases, the abdomen, 20%, bloodstream infections, 15%, and genitourinary tract, 14%. This should inform your decision on which samples you're going to routinely ask for. Clearly, the lungs are high yield, so whenever you're doing the septic screen, you should concentrate on this. It also goes on to say that among patients that had positive cultures, these patients were 70% of the total. So there is 30% that actually have infectious sepsis, but the isolates were negative. But among the 70%, we had gram-negative infections comprising 62%. And in that study, in their location, Pseudomonas comprised of the 62% of the gram-negative. Pseudomonas species were the most predominant at 20%, followed by Escherichia coli at 16%. The gram-positives, they comprised 20% of Staph aureus, and then we had the fungi at 19%. Very often we don't culture for fungi, but you can see it's a fairly prevalent source of infection, fungi. In a study done locally here in our ICU at Mulabo National Referral by Peter Agaba and others, it was found that in our ICU, Klebsiella pneumoniae, which took about 30% of positive cultures, was the most prevalent, followed by Acinetobacter species, which comprised 22%. And then we had Staph aureus in third position at 14%. There was a higher prevalence of multi-drug resistant bacteria, which was 58%. That's quite high, 58%. And of the 58%, 50% were actually E. coli species, and 33% were Klebsiella. And these also had extended beta-lactamase producing capability. So they were likely to defeat most of the cephalosporins and the penicillins. The Acinetobacter species, especially, were quite hardy compared to everything else. They had the highest rate of extensive drug resistance. Imipenem was the antibiotic to which most of these bugs would succumb. So this should inform your decision as to which cultures you're going to ask for, are they gram-negatives, gram-positives, and what empiric antibiotics you might want to use until you have your information back. In the patients on this study, ventilation, which is what a lot of the ICU care is about, and severe traumatic brain injury were very high risk factors for infection. So that was the local information we have. It's important when you're collecting these samples, you do it in the right way because there is a risk of contamination. Remember, we have microorganisms that we live with ordinarily, and these can still be cultured. The person taking off the sample can contaminate the sample with their own flora, which might give us erroneous readings. So in taking off the samples, it's important to scrutinize the request forms to be sure what has been requested, and then you consent with the patient in case they're awake, or the carers consent to obtain the samples. You should observe universal precautions and asepsis using protective gear, because most of these infections can still get you as a health worker. Then you should label your specimen containers, ensure that the patient you're drawing from is actually the patient you intended to draw from. And when you're drawing from a line, this is in regards to drawing a blood sample for blood culture. And when you're drawing from a line, you first take off 5 to 10 mils in a fast flash syringe. This should be able to take off a lot of the drugs that could erroneously give you misleading readings that you have just simply infused recently. And then you can draw your sample, and the flash can be given back, because if you to discuss this flash, considering the number of draws we do in the ICU, this would be an important source of anemia to these patients. Then the proper sequence in which to draw, you take off the blood culture sample first, and then you take off the coagulation tube, the serum tube, the heparin tube, and the purple last. It's important to know this because there are different agents that are in these tubes. And if you error in the sequence of drawing, you might have errors in the results you get because of contamination of the different tubes with the agents that are put in there. Then once you've drawn, you gently invert and mix the sample about 10 times. And then you should avoid decanting specimens from one container to another, obviously, because we have the different agents we put in these tubes to be able to perform different tests on them. And the specimens should not stand, they should be taken to the lab promptly. We should also avoid hemolysis. It's very often that we draw off these samples after we've tonicated extensively, or we draw off the sample and then we inject it into the percutaneous. Those are important sources of hemolysis, and these red cells contain substances that are supposed to be strictly intracellular, but when they leak extracellularly, they can give us spurious results upon which you can act. So there are risk factors for infection, and many of these bear in the ICU, but this can be said for most infections. So there are patient factors, environmental factors, and factors related to the organism. So patients in the ICU will often have significant comorbidities because they tend to be older. Their nutrition state is often poor. They're often immunosuppressed. They often have wounds, including the cutis ulcers that we tend to see in our ICUs, especially since we don't have very good one-on-one nurses to perform the regular skincare that is required. Patients in the ICU often have invasive devices, which might include our central lines, the urethral catheters, and so on. We perform multiple procedures on these patients. One patient could have intubation performed and central vein access and tracheostomy in one day, which is quite intrusive and can dislodge bacteria into the places where it shouldn't be, making it pathogenic. Prolonged stay in the ICU, we often see this. Ventilation itself, it requires us to introduce a foreign body into some places that should ideally be sterile, and then bacteria can migrate down this foreign body and set up an infection or any other motile microorganisms. We often expose the patients to prolonged antibiotic courses of 10 to 14 days. This environment favors bacteria to switch on certain genes that help with the resistance mechanisms that I'm sure I'll later discuss and will elaborate on. Then blood transfusions, especially in our ICU, we might let the blood stand for a while, since we might have bad venous access, and we may not transfuse all of these products in time, and very often they can be a rich source of infection to the patients. The environment, ICUs ideally are supposed to have good temperature control. They're supposed to have good ventilation, failure of which fosters an environment into which microorganisms can grow. Like Legionella likes air-conditioned places, badly air-conditioned places. We often have challenges with new and locum staff that may not implement the protocols that you set up in the ICU to ensure we don't spread infection. Then aseptic practice might be poor, and this might be because of shortages of the required sundries, but also the attitudes of the healthcare workers. The units very often are crowded, and there are often staff shortages. Like we know in our main ICU, we do not have one-on-one nursing, and we have so many people coming in and out of the ICU that could increase the risk for patients contracting infections. The factors for these organisms is resistance. We have at times seen in the ICU one specific species of germ infecting, like spreading like wildfire on several patients. Many of these bacteria are able to form biofilms, which are very difficult to penetrate with antibiotics, especially if you have invasive devices in the patient, like the central lines. Obviously, some organisms are more pathogenic and virulent than others. For instance, Saprophyticus, Staph saprophyticus is not as pathogenic or virulent as Staph aureus. And then the average prevalence of the organism on the unit, because we've seen Klebsiella is more common on the unit, so we expect probably the risk for getting Klebsiella higher in the ICU than on the general ward. The earliest microbiologist that seems to be known is this man, Van Leeuwenhoek, who was considered the father of the microscope. He came up with the first microscope, and with which he discovered a lot of the microorganisms, including protozoa, bacteria, and sperm, and he called these animalcules. This was the earliest microbiologist. The microbiologists are the people we trust to isolate, detect these microorganisms in the samples we give them, and to also give us the antibiotic susceptibility patterns. In identifying bacteria, this is the traditional way we do it. We would take off a sample and we culture it. Culturing is you get the sample and streak a bit of it. You could use a wire loop and streak a bit of it on a blood agar or a chocolate agar, depending on what microorganisms the clinician has suspected. So it's important the clinician indicates that they want to culture maybe anaerobes or fungi. Their clinical intuition should also guide the microbiologist in deciding which agar to use to be able to get a positive result, because these bacteria are very picky on where they grow. So first we can use the colonial characteristics, as we shall see in some of the images. Different colonies of bacteria will have different colors, they will have different texture on the agars that we shall see. And then we can use staining. This staining is very important because we know most bacteria, the most common classification of bacteria involves us knowing about gram stains, positive and negative. The shape of the bacterium, because gram positives can still be seen to be clusters or comma-shaped or rod-shaped. This kind of distinction helps us to have some sort of presumption on what the organism is. And then the fact that it might have flagellar spore formation that is typical of certain species and not others. Like for instance, Clostridium tends to form spores. And then certain bacteria are capsulated, like Streptococcus, Haemophilus. These are capsulated organisms. So if you do your microscopy after staining, you see the capsule. While you're culturing, certain bacteria thrive in oxygen-rich environments, whereas others only grow in oxygen-poor or deprived environments. Others are facultative in the sense they can switch between aerobic and anaerobic respiration, so they can thrive in both environments. Certain bacteria like cholera will grow at about 42 degrees, and then they would require alkaline pH, whereas other bacteria require lower pHs. And then some bacteria are fastidious in the sense that they need very specific conditions and nutrients to be present for them to be cultured. So too often you might have a negative culture result, but it's because you did not select the appropriate conditions for the bacteria to grow. There are biochemical tests that are run. Traditionally, you'd have to get a test tube. You have your organism in the liquid medium, and then you add like the oxidase enzyme, and then you see the change that happens. Or you add some nitrate or catalase, you add, and then you see the changes. These are usually pH changes that will give you an indicator change, or you might see bubbling, or you might see the bacteria swarm away from an environment they're not particularly familiar with, like urease secreting proteas. They tend to swarm away from acidic conditions. Then fermentation tests, all of this is in the biochemistry of things. We can also serotype the bacteria. For instance, this E. coli species that are implicated in giving us the hemolytic uremic syndrome, they have an O157 cell wall antigen and a hemagglutinin. They have further a flagyl antigen that is classified as 7. So you find it's written as O157 H7. That is serotyping. And then still, when it comes down to it, you have antibiotic inhibition patterns. We have bacitracin and novobiocin, for example. So certain organisms will be classified, will be identified in species by the fact that they are susceptible to novobiocin or not susceptible to novobiocin, as we shall see with the breakdown. So gram staining, when done well and early, can give us a hint on the possible cause of infection, and this can influence our decision in selection of drugs. Colony morphology will obviously delay because you need at least 48 hours to 5 days for you to see the colony. Acid fat stains will tell us about nocardia and TB. So all of these things can help us with getting a presumptive feel of what the potential invading pathogen is. Here are some images showing different bacterial species, different pathogenic organisms growing on agar. You can see the chocolate agar there, the blood agar. You can see Staph aureus in the clusters. You can see strep in the strips. And then you can see what a culture of Aspergillus would look like on subarachnoid dextrose agar. And when you see this, it will probably tell you that this is Aspergillus and influence your the way you treat the patient. These are more examples of what you could see when you stain different organisms. You see what the India ink looks like. And I guess everyone gets the idea of microbiology. You stain and then you have a look in the microscope. I'm not going to go through the intricacies of how gram staining is performed and how ZN staining is performed. But if you like, you could brush up on those facts, and you can actually go to the microbiology lab and have a look for yourself. So this is an algorithm that traditionally has been employed to try and classify this bacteria. You'll notice a lot of the bacteria you're familiar with are missing from this breakdown, but this is what traditionally was done. And they basically concentrate on bacteria that are of pathogenic significance. And so you can see gram-positive bacteria broken down into bacilli, cocci, and those with branching filaments. And then it comes down the aerobic and the anaerobic. The anaerobic bacilli, Clostridium species, the aerobic, there are several species under this. And these, there are more biochemical tests you can use to differentiate them. So in the cocci species, once you see them, there are those that are catalase negative, which are the strep, and then those that are catalase positive. Catalase is an enzyme that breaks down peroxide that is produced by this bacteria. and it gives off oxygen species. So you'll see some bubbling in the test tubes when you do the catalase test. Then we have when you go to the catalase negative side of things, there is we know now these are Streptococcus, but we need to differentiate which strep family are they. So there are those that do alpha hemolysis, which is partial hemolysis. So you'll see a green pigment on the agar. Then you hemolysis of blood cells. So you're growing this on the blood agar. Then you'll see complete hemolysis, and then you'll see no hemolysis. Complete hemolysis, you'll go to Strep agalactiae if it is bastracin sensitive, like we said, antibiotic resistance or sensitivity patterns are also an important way you can classify these bacteria. And then on the staph side, Staphylococcus are catalase positive, but in the staph family, then you can do a coagulase test. Those that are coagulase negative can be then classed into Saprophyticus and Epidermidis, depending on their sensitivity to an ovobiosine. And then those that are coagulase positive are Staph aureus. In the gram-negative side of things, we have this algorithm that was traditionally used. So after you've gram stained, you can see whether they are diplococci, and then depending on whether they are fermenting maltose, you can tell if they do ferment maltose, then it is Neisseria. If they don't, then it is gonorrhea or Moraxella. If you look at the shape of the bacteria and it is Coccobacilli, then the options are there: Haemophilus, Bordetella, Pasteurella, Brucella, and so on. If you look at the bacilli, they can still be broken down into those that are oxidase negative and those that are oxidase positive, which will be the Pseudomonas. Then those that do not have oxidase enzyme, they can be differentiated by the production of hydrogen sulfide into Shigella when they don't, and Salmonella if they do. And then you see the Citrobacter and Serratia, as well as the E. coli on the lactose fermenting side of the arm. Like we said, certain bacteria require specific growth conditions. Campylobacter grows at about 42 degrees. So if you have comma-shaped bacteria, but you need to differentiate which one is specific, then you can grow your culture at 42 and see what grows. You can grow the culture in alkaline medium, and you see Vibria will thrive, and then urea is producing organisms like Proteus, like H. pylori can also be identified. So these algorithms are very important to know, but at present, machines have been made that can actually do this process automatically. It's important to know these algorithms because the machines actually just simply use these algorithms, but they have very sensitive probes that can easily read these changes and be able to give you a result. So automated machines can identify gram negatives very easily, but anaerobes are very difficult to culture because they require very specific environment. So on these machines, very often you'll find the culture of anaerobes never shows up. And actually, most of the culture results we do get never have cultures of anaerobes. However, anaerobes are not as common. So there is that risk that we are missing them. And they're also a source of sepsis. There are machines that are semi-automated in the sense that for these ones, you need to first do like a gram stain. You identify that the organism is gram positive or gram negative. Once it's gram positive, there's a specific cartilage you're supposed to load that has all these biochemical reactions in small cubicles. It's like an ice tray, an ice cube tray. And each of the trays, each of the cubicles contains the ingredients or the substances you need for you to have these biochemical tests run. And then this cartridge is fed into the machine after you've identified that the organism you've cultured is a gram positive, and then you get your culture and feed it into the tray, and then the tray is fed into the machine, and the machine will automatically give you a reading very, very quickly. There are newer techniques that are very fast, but the challenge with these is they are usually organism specific, and very expensive. For instance, We have Gene Expert, which can do for you the identification of microbacterium very easily by using nucleic acid amplification technology, where a small sample of the bacteria's DNA or RNA strand is picked up and then multiplied several-fold artificially, and then the machine can then read for you the gene sequence and tell you about the nature of the organism. However, it may not read for you the gene sequence of Acinetobacter, for instance. So they are limited in that sense, but they can give you very quick results. They require less time, and they can also read for you resistance genes. By doing the gene sequencing, they can tell you if, like for instance, the Gene Expert can give you a reading of whether the microbacterium you've got is rifampicin sensitive or rifampicin resistant. So the advantage with them, however, is those that are really good are very expensive. Like the BioFire, they can detect those fastidious organisms. You remember we said because certain bacteria require very special environments to thrive. You can have a negative culture simply because you didn't give it the right environment. But for instance, the BioFire can detect even those fastidious pathogens. There are certain organisms that are very hard to culture, like chlamydia, Borrelia, difficult to culture. But the molecular techniques in these newer machines can actually pick them up. And also new organisms can be discovered, or new strains of the same old pre-existing bugs can also be discovered using these machines. This is images I took. These machines are readily available within the country. It's a BioFire machine that does nucleic acid amplification. But it costs about, I think, 1.2 million to run a sample. So people are not willing to pay for that. They go for the culture, which will delay and all that. This is a Vitec machine, which is able to do for you all the biochemistry, the biochemical tests, and give you a result within minutes. Once you've done the first culture side of things and you've got your gram-positive or gram-negative, then you feed it into a card, and that card will be read by the machine after a little while of intubation. And this is a Gene Expert machine. This Gene Expert machine can be modified to actually do, I was told by the people while making up the slides that they modified this to do a lot of the COVID tests that you see around town. So you're able to modify the cartridges. You can unload some software. You can actually trick it into reading different things. I don't know what the spectrum stops at in that sense. Then beyond the culture, the microbiologists are going to give us susceptibility testing that will influence our choice of antibiotics, especially in the ICU, where this is very critical. So what actually happens in susceptibility testing is there are methods that are phenotypic or characterized by physical appearances of the bacteria. So what happens is we have the disk diffusion method. This, I'm told, is the most popular method in low resource settings like ours, and indeed is the one that's predominantly performed at the Macquarie University Pathology Lab, Microbiology Lab, where we send our samples. Basically, they put after you've done a culture, they get different discs of antibiotics, and they are placed on the agar that has cultured different bacteria, and then we measure the zones of inhibition around each of these discs. And after we've done that, the wider the zone, the more sensitive the antibiotic is, rather the bacteria is to the antibiotic. We have a different method that typically is used in the machines, in the like the Vitec that we saw there, where now each of the trays, like I said, this will be like an ice cube tray, but really small. And they will put different serial dilutions of different antibiotics. And then they will introduce a standard inoculum of bacteria into these different cubicles of the ice tray. And they will see usually the bacteria will continue to grow and increase the amount of turbidity within the different cubicles, and the machine can read that turbidity very sensitively and interpret it as how much of the bacteria is growing. And this can also be used to tell us, because we already know the dilution of antibiotic within each of the cubicles, can tell us about the minimum inhibitory concentration of the drug, or the lowest dose that can knock out this bacteria. But of course, this is in vitro. So in vivo, the changes, there might be a bit of a change. Yeah, so the other issue to note is, because we, okay, the other issue to note is because we are limited in the number of antibiotics we can test for, the lab has to actually determine which antibiotics it's going to test for. So very often you might see a long list of antibiotics that a bag is non-susceptible to, but actually, maybe if they did a different list of antibiotics, this bag would definitely have something that it is susceptible to. So it's very important that the lab chooses the antibiotics against which it can test routinely for us to have useful cultures. There are molecular methods, like we said. For instance, a gene expert can detect resistance genes in a strand of DNA of the Mycobacterium. So that also helps us with microbial susceptibility testing. The other thing I didn't touch upon is molecular methods can, although they are very specific to the pathogens that they detect, they can literally read for you most of the organisms, since all of these DNA is the molecule of life, and these molecular methods can manipulate a lot of these DNA strands and give you results. So it's cross-cutting from bacteria to parasites to fungi to viruses, although it's a not widely available method, and also it's quite expensive for most of our patients. This is to show the main way we test for antimicrobial susceptibility using the disk diffusion methods. You can see these are disks of antibiotic, and the zone of inhibition is that clearing around, and these are ideally bacteria that are growing around each of the disks. And so inherently, this has a smaller diameter, this has a bigger diameter. So this antibiotic is likely to be more sensitive. So you can use a vernier calipers, like in this image here, to measure the zone of inhibition. And this can be compared against standard charts to actually predict what the minimum inhibitory concentration of that drug would be. And then the microbiologist feeds that into a report and sends it back to you. Another thing that we need to touch upon is hemoparasites and other special stains. We use GM sustaining to look at many of these hemoparasites, like the trypanosomes. You can see them there, and then the very common malaria in the ICU. You can see the ring forms. You can also see gametes here in this slide. We don't have any gametes, but also it's common to see gametes for malaria in the GM sustaining. So this isn't very exhaustive, but it gives you an idea of how the microbiologists come up with some of this stuff that they send back to us upon our request. Those are my references. Thank you very much.
All right, thank you very much, Dr. Fred. Those were, I think, exhaustive points that you've raised. So since we are badly running out of time, allow me to request the audience if they have any questions to ask you, and then we can proceed. I think there was a question from Bashir, but Dr. Rasmus suggested that perhaps we wait for the end to see if the question is answered. I think we can still push that question to the end and see if it will be answered. So if there are any questions from the audience, please just raise your hand and we shall allow you to unmute so that you can ask your questions. However, in the meantime, since there are no I don't see any hands raised at this moment. Allow me to perhaps go into the poll questions, and I will call on Dr. Erasmus and yourself to respond to some of the poll questions that have been responded to so far. So regarding sepsis microbiology, do you think, Nsereko, do you think viruses do cause sepsis?
Yes, viruses are indeed a very important source of sepsis.
Okay, and I think that can also be seen with the COVID-19 pandemic. Those patients actually did qualify to be called patients with sepsis. And I think you also agree that malaria does the same. So I think we shall move on to the next poll question that the audience responded to. So do we have any gold standard tests for sepsis, to diagnose sepsis?
No, we do not have a gold standard test for diagnosing sepsis. However, we use the whole range of options that I just discussed briefly, including biomarkers, including the clinical history, and then the physical exam findings to diagnose sepsis.
All right, thank you very much. And then regarding the number of patients who we believe have sepsis, do you agree with the majority of the audience that approximately 1 in 3 of patients diagnosed with sepsis actually don't have it but have non-infectious conditions?
Yes, I agree with the audience.
All right. I think this is really based on a lot of observational studies that eventually have been found to have patients who initially seem to meet the criteria for sepsis. Actually, about 30% of them actually have non-infectious conditions. So that means 2/3 of the patients we actually find actually do have sepsis. So we need to be very cognizant of that. And then regarding sepsis microbiology, I think let's go to the one for diagnosis, which you've been responding to. So regarding administration of cultures, or taking off cultures, do you agree with the audience and the Surviving Sepsis Campaign guidelines that we should give antimicrobial therapy if there is anticipated delay of more than 55 minutes?
Yes, antibiotics should not be delayed because of a delay to take off a blood culture.
Okay, all right. And I think the audience did agree with that. And then there was this question regarding which of the following statements regarding blood cultures cannot be drawn after antibiotics have been initiated, best drawn at the onset of rigors in a febrile patient, or the other option was central line blood should never be taken for culture, and then I'm not sure. So any thoughts on this?
So the best possible time to draw blood cultures is before the initiation of antibiotics, because this may not coincide with the rigors. However, should the rigors be there, the yield from your culture is likely to be much higher, but you cannot defer drawing a blood sample because someone doesn't have rigors, and very often the patients you're admitting may not have the rigors. So the best possible time to draw them is at the point when you first interface with the patient, and then you initiate the antibiotics. Initiation of the antibiotics does not annul the fact that you can do cultures. However, the yield from your cultures is likely to be negative if antibiotics have been given.
Okay,
central line blood can be taken for blood cultures, but it's also important to do a peripheral draw, because sometimes the culture you're taking from the central line will just show you the bugs that have been introduced from the skin surface or that are in the lining of the central line, but not necessarily in the bloodstream. So if you corroborate that with the a peripheral draw, you might be better placed to adjudicate bloodstream infection.
Right. So I think it's extremely important to know that if you have to put a central line in the patient, and that's probably within 1 hour of seeing them, that's the best time to actually take off the blood culture. Usually when you're preparing for central lines, we observe maximum, or we should observe at maximum aseptic technique. And once that line is in, it's appropriate that you draw the samples at that particular point in time. That's when you probably have the least contamination. All right. So then we can go into the other questions. I think the other questions related to, just a second, sorry. Okay, there was this question regarding the most common cause of septic shock in the ICU are multi-drug resistant bacteria. The audience said 53%. It's correct. What are your thoughts on this, Fred?
Yes, I believe this is correct. From the study that Dr. Peter Agava and colleagues did, the incidence of multi-drug resistant organisms was quite high. It was 58%. So this is indeed a very common source of septic shock in the ICU.
Okay. I think that at this point, I think there was, I think we have completed most of the questions that the audience has responded to. I will request, I'll probably request you to stop sharing your slides, and then we shall go into the next phase, and I will introduce the next presenter. Okay, so okay, so the next presenter for this particular CME is Dr. Peter Waswa. Just a second. I'm trying to get his face for you to see. So Dr. Peter Waswa is a currently anesthesia critical care specialist who has completed his master's and is a fellow of critical care medicine with a scale program. And he is going to tell us about the microbiome and sepsis, which I think is a very interesting topic that some of us may have not been aware of. But as he prepares to share his slides, we'll launch the next poll to try and see what our thoughts are regarding, first of all, what Dr. Fred has shared, as well as what Dr. Peter Waswa is going to tell us. So, Dr. Fred, if you're still there, the audience is going to respond to a poll on diagnostics. So here is the poll. And this poll is asking regarding blood cultures, how many blood draws are regarded adequate for organism yield in culture? Okay, so we shall allow up to 50% of the audience, and then we shall close it. So answer as fast as you can so that your voice can be heard. If we hit 50% before 1 minute, then we shall close. We can allow it to go up to 1 minute, but if we hit 50% towards the end of the minute, then we shall close the poll. Okay, I think we are almost at the minute mark. I do not see any more answers coming in, so I'll end the poll. So these are the results. So Dr. Fred, any thoughts on this? The audience says we should take at least 2 blood draws, and that is regarded as adequate for organism yield in the culture. What are your thoughts?
Yes, you can do 2 blood draws are indeed good enough. But at a later date, you might have to draw more blood. So I don't know, in terms of temporal arrangement, you might draw more blood samples later on, but at the onset, 2 blood draws are good enough.
All right. I will push this question further down the presenters to Dr. Katongole to prepare to respond to that question also. And then the next question is also related to diagnostics. So just a second. Yes. So here is the next poll question. So upon culturing sputum specimen from a febrile patient admitted to the ICU with pneumonia, gram-positive cocci in chains are identified. These are likely to be, all right, so responses are welcome, and we shall close them either at the top of the minute or when we hit 50% of the audience. So gram-positive cocci in chains. This is basic microbiology, which Dr. Fred has eloquently elucidated on. Okay, we are almost at the top of the minute, so I will end the poll in 2 seconds. So that's the end of our poll, and these are the results. So 83% of the audience said Streptococcus pneumoniae. Fred, any submissions to this?
Yes, this is correct. Strep pneumoniae will be chains. Staphylococcus aureus will be clusters.
All right. Thank you very much. I will, I think, have one more question for the audience, and that will be it for diagnostics. So if more than 2 microorganisms are isolated from a urine specimen, the right interpretation is likely to be, so we can select any of the options, and then we shall end the poll. Okay, I think we are having nearly 50% of the audience has responded. So we shall close it as soon as we hit the mark or a minute passes. All right, I think I will close the poll here. So the audience says colonization, 89% of the audience chose colonization. Fred, any comments?
This I have not read up, to be frank, but I would think it's colonization.
All right, so we shall also push this question down the chain to the microbiologists to tell us what we should think when we see 2 microorganisms. All right, so while we are thinking about Peter Waswa's discussion, let us first perhaps look at some of the questions on microbiome and sepsis. And so this is the first poll question that I'm launching now. Severity of critical illness is associated with increased risk of MDR or sepsis, multi-drug resistant organism sepsis. Is this true? Is it false? Or you're not sure? Okay, we are almost at 50% of the audience. It seems like when a third of the audience has responded, the answers do not really change. Okay, so I will end the poll question here. We have hit 50%. and share the results. So Dr. Peter Waswa, please get ready to respond to this at the end of your presentation or during your presentation. And 80% of the audience agrees that the rate of illness is associated with increased risk of multi-drug resistance organism sepsis. And then the next question on microbiome and sepsis is here. So disruption of microbiome increases the risk of dysregulated immune response. Is this true? Is it false? Or I'm not sure. All right, we have nearly 50% of the audience so far has responded, and I'm about to close the poll. Okay, I will close the poll here. Again, nearly 80% of the audience agrees that the disruption of microbiome does increase the risk of dysregulated immune response. Okay, and then the final question on microbiome and sepsis is here. So antibiotics disrupt intestinal microbiome, increasing the risk of multi-drug resistant bacterial sepsis. Is this true? Is it false? Okay, so I think Dr. Peter Waswa, you have your work cut out. In a few seconds, I will be closing this poll and allow you to proceed with your talk. All right, I think I will close the poll now. And these are the results. 83% of the audience does agree that antibiotics will disrupt that and increase the risk of multi-drug resistant bacterial sepsis. All right, thank you very much, audience, for responding to those poll questions. Dr. Peter Waswa, please take it away.
Hi everyone, so I'm Peter Waswa. I'm going to be taking you through the microbiome and sepsis. I hope you can all hear me. So when we talk about the microbiome, we are basically referring to the genetic material of microbes that reside in a particular environment. So the human microbiome, when we talk about the human microbiome, we're basically talking about the genetic material of microorganisms that reside in the human environment. So those microorganisms are going to include things like bacteria, fungi, viruses, and the protozoa. So to note, the human microbiome is made up of about 2 million genes of the microorganisms that are within about 20, some data says 20,000 genes, some data says about 23,000 genes of the human genome. Maybe to note, within the human microbiome, viruses actually do outnumber bacteria in a ratio of about 5 to 1. And these microorganisms actually do reside with us in a more of a symbiotic relationship. So we benefit, and then they also benefit. So what are some of the benefits of these microbes when it comes to the human body? Some of the vitamins that we use in the body are actually synthesized by these microorganisms, the important bacteria, the commensals, which sample capture the flora. And then through their interactions with attachment sites and then competition for nutrients, they protect our bodies from colonization by the pathogenic microorganisms. And then some of them have bactericidal properties through the interaction with some of the receptors, for example, in the gut lumen, which end up inhibiting and killing microorganisms. And then They also play a role in the immune system of our bodies by stimulating the development of certain tissues. And then, because of the changes within their genomes, end up with cross-reaction of antibodies that are always important in prevention of infection and invasion. So, to know the human body, the microbiome of a human body has variable composition from the different sites. Now, as you can see in the displayed chart, those are pie charts taken from different parts of the body, displaying the distribution of the different organisms at the different body sites. What is noted is the distribution keeps on changing from the different body parts of a given individual, and it also changes from individual to individual. We are going to learn factors that may lead to alteration of an individual's microbiome. Even when it comes to looking at one individual and analyzing the microbiome of just their upper limb, you find that different parts of the upper limb have different distributions of these microorganisms, and they all play a given role in maintaining the body of this individual. So how do we acquire our microbiome? So someone begins acquiring their microbiome within their mother's uterus. So when you're in your mother's uterus, you're birthed by amniotic fluid, you take it in and then you pass out within the same environment. So it contains bacteria, it contains viruses, so we keep on taking them and they keep on modifying our microbiome. The nature of birth also has an influence on the microbiome. Babies that are born by SVD do acquire microorganisms from their mother's tract. And some of those microorganisms actually are important. For example, lactobacillus in the digestion of milk. Those that are born by SVD do acquire some skin components from the mother. Even during breastfeeding, we keep on getting microorganisms from the mother's breast into the baby, antibodies. And then, even in the environment that we live in, we get organisms from the water we drink, from the soil, even some of the foods that we eat, from people when we hug, when we shake hands, those that love pets, small animals at home, and then from plants. And they all contribute to the diversity and complexity of our microbiome. To note, the diversity of the microbiome is going to change as you grow. So we expect an infant to have not really a rich microbiome, which is diverse, but as you advance in age and you keep on interacting with different environments, acquiring different microorganisms, your microbiome keeps on getting modified. So what has been done about the microbiome in the past 20 years? So from 2004 to date, this was a data search on PubMed, and the keywords were microbiome and sepsis. And found that people are gaining lots of interest in the microbiome and sepsis to the extent that the papers that are being published about the topic have been an upward trend. 2022, we are not yet even at the end of the year, but almost hitting the number that was published last year. So that's how important this topic is. So why do we have to study the microbiome? So understanding of the microbiome is going to help us understand how to reduce the incidence of sepsis, how to improve the outcomes of sepsis, and also how to reduce mortality after sepsis by understanding how to interact with the microbiome, how to modify our feeds, and how to choose antibiotics. So alteration of the microbiome is associated with changes and proliferation of bad microorganisms. And the microbiome altered, so these microbiomes, how they interact with the different body parts within the body. So the microbiomes that are going to be altered in a given body site are going to lead to a change or pathology in that different site. For example, when there's a microbiome within the respiratory system, we're going to end up with things like VAP. Whereas when you come with the alteration, the microbiome within the gut, you end up with things like inflammatory bowel disease, and then things like ulcerative, things like colitis, and then postpartum difficile colitis. For the purposes of this discussion, I was not able, at the time, I'm not able to discuss microbiome for the different body systems, but let me talk about the gut. So this slide is a cross-section of the gut barrier. So what you can see is that the gut barrier has gotten about 3 layers of defense. So the first, so the first layer of defense are the microbial organisms that are going to be important in, they play so many roles. For example, when you eat dairy fiber, these microorganisms do participate in the fermentation of these dairy fibers and then breaking down large polysaccharides to small chain fatty acids, which small chain fatty acids are going to play a very big role in reducing on the intestinal transit time and also ensuring that the intestinal epithelial cells have the mucus lining, which plays a protective role in keeping these microorganisms from translocating to other body parts. Then the next is the intestinal epithelial cell, and then the immunological layer, where you find immunological cells like macrophages and then dendritic cells. So the most important things to pay attention to on this slide are the membrane-associated molecular patterns, reg-3 gamma, which is a bactericidal C-type leptin, which is found within the intestinal epithelial cells. So it plays an important role in the regulation of microorganisms that are pathogenic from invading our bodies, and then the cell layer. So what happens is, in normal mechanisms, activation of toll-like receptor 5 binds to the dendritic cells, which are going to release interleukin 23, which is going to stimulate production of interleukin 22, that leads to excretion of this bactericidal C-type leptin. It's going to be playing a very big role in the protection of lining from other microorganisms. So what happens? Okay. So what happens in sepsis? So in sepsis, we end up with a dysbiosis. Dysbiosis means we're going to have an alteration of the microbiome. So with sepsis is associated with a hyperpermeability state that starts about 1 hour deficit of sepsis and persists about 48 hours. So during that time, so these microorganisms that are found within a microbiome play a big role in the release of pro-inflammatory mediators and pro-inflammatory cytokines. So when someone gets sepsis and they're in a hyperpermeability state with release of microorganisms that are commensals protect us from inflammatory issues. They give us anti-inflammatory mediators. So with sepsis, we are going to have pro-inflammatory cytokines release, and then you're going to end up with disruption of tissue, and then the cells are going to become, the barrier is going to be disrupted, organisms are going to be translocated from the gut lumen to other distant sites, and then in the end, you're going to end up with organ dysfunction, and then over-proliferation of organisms that actually not meant to be commensals. So, what are some of the things that are going to lead to a dysbiosis? So, with dysbiosis means you're going to end up with loss of diversity and richness of our gut our microbiome. Such that with advancement in age, you're going to end up with an increase in the complexity and the rest of your microbiome. So diet, how does that contribute to the microbiome? So some kinds of feeds have been found to play a big role in maintaining the gut microbiome, for example, the fiber, and other feeds have been found to play a role in disrupting the gut microbiome. What has been studied, what are some of the things that have been studied have been kind oils and people that take sunflower oil versus those that take olive oil. You find that when you assess their microbiome, they're going to be totally different. And then also whether you're taking a vegan diet, whether you're taking a Western diet, it also has an influence on your gut microbiome. So stress. So stress is associated with release of cortisol, disruption of internal nervous system, release of epinephrine, formation of lactate, and it also has an important role it plays in the disruption of your gut microbiome. So critical illness, we're going to talk about it. So antibiotics, so when you give broad spectrum antibiotics, what happens is they are going to clear everything they find. What happens is some of your important microorganisms of your microbiome are going to be altered, and then you're going to end up with things like diarrhea. So proton pump inhibitors, those ones have an effect to do with disruption of the release of gastric acid, and then affecting the organisms that thrive within low acidic pH. And then opioids, it's to do with reduction in the transit time of the gut. So with dysbiosis, you are going to have reduction in the production of short-chain fatty acids, which is going to lead to reduction in anti-inflammatory cytokines and loss of gut barrier integrity with an increase of those cytokines. So a study was done to see how the microbiome changes in critical illness. So they took off samples from healthy patients and then those that are critically ill. So what can be noted is as you advance from healthy, someone who's healthy, to someone who's critically ill, you have that commensal bacteria in green is actually reducing in number, whereas opportunistic pathogens are increasing in number. Formicutes are important for troubled and then bacteria. So these are important bacteria. So for them, they are reducing in number with critical illness, whereas proteobacteria is going to be increasing in number, which is actually harmful bacteria. So this is going to introduce reduction of the mucus layer, reduce production of small chain fatty acids, and then the intestinal epithelial cell integrity and permeability is also going to be disrupted. So we are going to have reduced absorption of the nutrients, an increase in the pro-inflammatory immune response, and then secretory diarrhea. So still a study was done to see what happens to patients. So these patients were followed up. So patients that were healthy, that were admitted with conditions that are not sepsis, those that are admitted with sepsis. So these patients were followed up to see what happens for 90-day readmission at 3 different exposures, without an infection, with an infection, and with C. difficile infection. So what happens is patients that had been admitted with no sepsis had almost a consistent probability of admission for the 3 different predispositions. Whereas patients that had been discharged following severe sepsis had a consistent rise in the probability of being readmitted with their 3 different exposures. So what causes these predispositions actually multifactorial, but antibiotics also play a role. So still, in the US, they did a study to see how the microbiome changes with patients admitted in the ICU. So samples are taken off from these patients, fecal samples, oral samples, and then skin samples. But I just displayed the fecal and the oral samples. So the graphs above show the microbiome at 48 hours of admission to the ICU. This is for the fecal sample, this is for the oral sample. And then you can see, so these were 115 patients whose microbiomes were reassessed on day 10 in ICU or at discharge. So what can be noted is, with the critical illness, the gut microbiome is actually totally altered. So how does the body respond? So when the body is prior to sepsis, the gut microbiome leads to there's an overgrowth of pathogenic intestinal bacteria, and the body is preparing for inflammation, and then we're going to have reduction of small chain fatty acids. So with sepsis, we are going to have, of course, because of the inflammation and then the changes, we're going to have increased susceptibility of organ dysfunction with disruption of the gut barrier and translocation of microorganisms to other organs. So in summary, dysbiosis and sepsis is actually a vicious cycle. So what happens is, when you have dysbiosis in a body site, it's going to lead to proliferation of these other microorganisms. Organisms are going to, the disruption of gut barrier is going to translocation of these unnecessary microorganisms to other body organs, inflammation, hypoperfusion, and then life-threatening organ dysfunction, which is sepsis. Thank you for listening. Those were my references.
Thank you, Dr. Peter Waswa. That was, I think, a very elaborate and clear presentation, and I hope that the audience has appreciated the role of microbiome in preventing us from getting sepsis, and also the role of antibiotics in disrupting microbiome on our bodies. It's quite interesting, a discussion that you've raised, and I hope that there are questions that are coming from the audience. And as we wait for the questions, please put your hand up, and then we shall allow you to unmute. In the meantime, Dr. Peter Waswa, I will direct you to our questions regarding microbiome and sepsis, and find out what your thoughts are. So the first poll question was about severity of critical illness being associated with increased risk of MDR or sepsis. The audience says 80%. What are your thoughts on this particular poll question?
I agree with the audience that severity of critical illness is associated with an increase of viral sepsis. Maybe what I can note for them, one of the receptors within the intestinal epithelial cells, which when it's underexpressed, patients are going to be predisposed to vancomycin-resistant enterococcal infections. So yes, it is true. Because the more sepsis, the more the disruption in the gut microbiome.
Yeah, that's true. Thank you very much. And then the next question is again about microbiome, was regarding the immune system and disruption of the microbiome. 79% of the audience says yes, disruption does cause increased risk of dysregulation of the immune response. Any particular thoughts on that?
I do agree with the audience because
Yes, please go ahead.
Yeah, because disruption of the from the discussion, disruption of the microbiome is going to be associated with proliferation of the pathogenic microorganisms and translocation to other body organs. So with more pro-inflammatory mediators, and which would mean we are going to end up with a dysregulated immune response. So I do agree with the audience. Yes.
Okay, and then antibiotics disrupt the microbiome, increasing the risk of multi-drug resistance bacterial sepsis. Again, 80% of the audience says that is true. Any thoughts on that?
I agree with the audience. It is true.
Okay, do you want to throw a little bit more light so that the audience can know why you agree with them?
Quite often, we give patients broad spectrum antibiotics, which are not specific to a given microorganism. So in the end, we end up also eliminating microorganisms that are going to be important in our body. So once that is done, we end up with even things like inflammatory bowel syndrome, and then some of the organisms end up undergoing mutations, and then in the end, we are going to end up with a resistance to antibiotics.
All right, thank you very much. Before we go into the next and last presentation for the day, let's first respond to these poll questions. And the first one is here. Candida albicans isolates in sputum of intubated ICU patients or urine of catheterized ICU patients is generally a colonizer. Is this true? Is this false? Or I'm not sure. So I think I will welcome Dr. Paul Katongole to respond to these ones during or after his presentation. As the audience responds to this, we shall see the results shortly. Okay, so I'll end the poll here and then show the results. So 56% of the audience says yes, that is true. It's mostly a colonizer. And then the next question is also similar to that, again about colonization. So how long does microbial colonization of patients who have previously been hospitalized with MDR organisms last? Okay. So how long does microbial colonization last? That is the question. If you have been colonized before, from hospitalization and you go home, how long do we expect that this will last? Okay, I'm going to end the poll here. And this has been inconclusive from the audience. So I think there was a tie between up to completion of therapeutic 2 weeks of effective antibiotics, and then another up to 1 month after discharge from healthcare environment. All right, we shall get the responses to that. And then the next poll questions will be related to multi-drug resistance risk factors for patients. So risk factors to multi-drug resistant organisms in the ICU include all the following. So you can select any of the options that apply. You can select more than one. If you want to select 3, it's up to you. You can start responding now. Okay, at the top of the minute, we shall end the poll. Okay, so I'm going to end the poll now. All right, thank you so much for responding. From the audience seems to think perhaps it's mostly long hospitalization, frequent encounter with healthcare settings, and comorbidities. Those were the most high ranking. All right, and then the next poll question is also about multi-drug resistant organisms. So which of the following pathogens are the leading causes of nosocomial infections globally? Again, you can select more than one option of these, and feel free to start selecting your options. Okay, very interesting results are coming in. I will be ending the poll in a few seconds. All right, I'll end the poll here and share the results. So 86% say Klebsiella pneumoniae and 76% chose Pseudomonas aeruginosa. Those were the most high ranking, followed by Staph aureus. All right, and then we can jump into some of the microbiome treatment that Dr. Peters was mentioned. So regarding fecal transplant, would that be effective treatment in treatment of C. difficile in the ICU? Do you strongly agree, you're not sure, disagree, or strongly disagree? So fecal transplant in treating C. difficile, can we actually give fecal matter to the patient and treat Clostridium difficile in the ICU? I think this is a question Dr. Erasmus is very, actually that's not the word, is extremely passionate about. I will stop the poll now and then share the results. I think there is a big percentage that agrees. However, there's still a big percentage that either disagrees or is not sure of this. So Dr. Erasmus, get ready to respond to that. And then let's go into the IPC, and that's going to be part of the next talk. And there are 3 questions on IPC. Contact precautions in infection control mean the following interventions. So select only one option and then submit. Contact precautions in infection control mean the following. interventions. All right, I will end the poll at the top of the minute, which is shortly coming up. Okay, I'll end the poll now. So these are the results. 56% of the audience mentioned hand washing, gloves, and gown. And then the rest selected the others. And then second last question on IPC, alcohol. This is about alcohol-based hand hygiene is superior to traditional soap and water in eliminating bacteria. Is this true or false? And I think Dr. Katongole will also respond to this one. Dr. Katongole is a microbiologist and also a PhD fellow, and in the Department of Microbiology, and is also a lecturer at Macquarie University, and he will be giving the next talk. So as we go for the last poll, I will request Dr. Katongole to share his slides and start as soon as we have completed the last poll. So I'll end this poll here and then share the results. And so 75% of the audience says no, water and soap is better than, or alcohol-based hand hygiene is not superior to traditional soap and water in eliminating bacteria. We shall again hear from Dr. Paul Katongole regarding that. And then finally, the last poll question for the day is here. In which of the following patient infections would droplet precautions by clinical staff be mandatory? COVID-19, anthrax, disseminated meningococcinemia, and then Staphylococcus aureus wound infection. When would droplet precautions by staff be mandatory? Okay, Dr. Paul Katongole, please share your slides.
Thank you, the presenters, for this session today. I'll start with an opportunity give a talk. I was planning to make slides earlier, and then I was quickly called for the Ebola response in Mubende. So I've been in Mubende since Tuesday, and we've been up and about. So I didn't get a time to make slides. But on the good note, I would like to request the members of this group to switch their heads away from the science that Peter and the other colleagues were discussing, the serious science. We are going to talk about simple, basic things that are very practical that can be done while in the ICU to really prevent infections, and what are some of the practical infection prevention and control measures that can be utilized by all healthcare workers in the ICU. So I'll start with basically talking about IPC in general. So infection prevention and control basically relies on the fact that we implement principles and practices that are aimed to curtail transmission of infections from the health workers or from the community, the parties, and to ensure that this process really does not lead to increased transmission of hospital-acquired infections. So when we talk about infection prevention and control, we basically talk about what we call the 8 core components of infection control. And these 8 core components which are a bedrock of IPC, include the following. We include what we call the IPC programs, and these programs are basically more of a leadership. Do you have a functional IPC committee? Is it functional enough that it meets regularly? Do you have leaders on these committees? Do these leaders have people of responsibility that are able to take actions and implement the measures that are taken or decided upon? Do you follow guidelines? So there are international guidelines, there are local guidelines of IPC. Do you really have these guidelines to follow? Do we routinely and periodically train staff on the basic principles of IPC? That's number 3, training and education. Then the number 4 is basically what we call hospital-acquired infection surveillance. So how often do you do surveillance of organisms or multi-drug organisms that are circulating in this facility? So that is HAI surveillance. Then the other number 5 is what we call the multi-modal strategies. So the multi-modal strategies are a principle of strategy that are 5 that we shall talk about a bit later, that should be used to monitor the different processes of IPC in the facility. The number 6 are monitoring and evaluation of the program to ensure that we understand what is happening, to ensure that we get feedback, to ensure we evaluate our processes and all that. And then number 7 is about the staffing level. So we should understand that for you to be able to practice basic principles, you need to have a staffing level that is adequate enough to be able to distribute the work and attach responsibility. Things like bed occupancy and things like staffing are very, very important, because the IPC does not thrive in areas that are overcrowded. That is very, very important. I'll give you an example. I think 2-3 weeks ago, I was called by the head of surgical emergency in Mulago to go and help them do environmental sampling of the surgical emergency. Just a tour of the facility, I called the surgeon and told him, we are going to do the environmental sampling, but in terms of implementing the strategy that we need to implement, it might be more or less impossible, because where are you going to disinfect? Where are you going to practice the principles of instrumentation and everything? When the corridors, everywhere you move, blood is flowing, there's no system. So overcrowding is really, really an impediment to IPC practices. And then the last component, which is component 8, is what we call the built environment and equipment and materials. So built environment talks about how is this facility set up in order to provide a smooth arrangement that facilitates IPC. World over, the standards are that before a hospital is built or before any health infrastructure is built, the drawings and the architectural plans should be done in consultation with IPC teams to ensure that proper flow of patients, proper aeration, proper distribution of things and everything that needs IPC is put into consideration. And this is something that even the ministry currently is grappling with, because oftentimes we got a big problem in Mulago when we had COVID-19, just because Mulago is IPC friendly. So for example, we never had a streamlined flow where healthcare workers would don in and work on patients and walk out without using the same floor. And this was a big problem, and we failed to manage it because in an up and everything. So this should be part. So now briefly to talk about what we call multi-modal strategy. Like when you setting up, for example, an IP program, the first
Dr. Kotongole, we keep losing you audio. Perhaps the network connection where you are may not be very good. I don't know if you can just improve a little bit by maybe finding another location. Thank you. Dr. Cornelius, it appears
hello.
Katongole's audio.
Yes, Dr. Katongole, please proceed.
All right. So sorry, my network was a bit bad. So what I was saying is that the next thing would be to after building the systems change, then you talk about things like training and bring everyone on board that is part of your team. Then after that, the next thing will be you need to put checks and balances to ensure that you check how strong your systems are. With this is a bit of an M&E component. And then after that, you make sure that when you set up this system and functioning and you're putting up checks and balances, then the next thing would be to ensure that you keep reminding the people on what they need to do. So when you have an IP system that, for example, that is always moving ahead, you put up reminders and communications. Find out, are things moving well? Find out, are people doing proper, for example, disinfection? Find out, are the meetings happening? So this is more of a reminder and communication. And then when you keep doing this over and over again, your expectation is what we call a culture change. So you've set up a system, you've trained everyone, you've tried to check back and forth, remind everyone, and everything is in place. So you think that over time, you will have a systems change, and then people will be on board. So then the other thing would be that we talked. I want to talk about is in terms of IPC, what basic principles of cleaning, disinfection, and sterilization. So oftentimes in a facility, when you have a strong IPC team, it's important that you bring very closely the cleaning team. So this cleaning team is basically normally comprises of cleaners, hygienists, and everyone. So it's important, one, to have a very well-trained team to know exactly what to do. But oftentimes also there are basic principles that need to be followed. For example, there's what we call the 4-bucket system for cleaning and disinfection of equipments, where you expect that, for example, if you have equipment, you have 4 buckets, and the first bucket is of soapy water, then the second bucket is of clean water, then the third bucket is of the disinfectant, and then the fourth bucket is of clean water. So all this, for example, the soapy water is basically to try and clean, first of all, this equipment and ensure that they are just clean with the soap, remove any kind of debris on there. And then the second bucket is to rinse that off. And then when you rinse that off, you ensure that now the equipment are now finally put in the sterilizing agent, which could be maybe a chlorine, the percentage 0.5, and then and why you ensure that you put the equipment when it's clean is to avoid the chlorine normally tampers with any kind of agent that is on the equipment before when it's not clean. So then finally you also rinse that. So those basic principles, even principles of cleaning as basic as cleaning of surfaces, it's important that, for example, when a patient vomits on the ward, you don't just pour a disinfectant onto the surface. It's important that you first immediately clean with soapy water, and then after that, then you put a disinfectant, and then you put it and you wait for what you call the contact time. So the contact time is to ensure that the disinfectant has an effect, which normally takes between over maybe a few 30 seconds to 1 minute, and then later on you clean with soapy water and then rinse the whole place. So these are basic principles of cleaning and disinfection. But oftentimes when you walk in the wards, cleaners don't really know what to do, and the health workers have not trained them into understanding some of these things. Then the other things that I had the team talk about is the standard precautions, the transmission-based precautions. So it's often important to understand the transmission of agents that are happening in the world. But oftentimes in AMR, most of these agents, especially the multi-drug organisms and what, are more of contact-based precautions agents that you need to practice. So isolation is very, very important when you're practicing contact-based precautions, avoiding usage and the mixing of supplies with these patients that have been identified to have MDR.
Farm against these microbes, and especially prevent infection transmission across patients in the unit. We will be concluding the session now, but next week we continue our sepsis series, the last segment of the series, which will be pharmacotherapy. Come back in your big numbers, come back attentive, go and read around pharmacotherapy, come with questions, make the conversation very much fun with all your participation. And I guess finally, a big vote of thanks to our presenters for honoring this invite. Mr. Samuel Olowo, thank you for responding on short notice and sharing the findings of this study. This is the first step of dissemination, and I hope that the comments you received here will help to improve the paper, and hopefully we shall see it in the journals very soon. Fred, thank you so much for dissecting the microbiology and the approach to diagnosis. And Peter Waswa, I would like to believe that most people are hearing about this topic for the first time, and maybe we knew a bit about it, and now we have actually had a bit of an exposition to it, thanks to you. And then Dr. Paul Katongole, we know you're a very busy man right now, and as usual, frontline staff doing the amazing work of keeping people safe. Thank you for what you're doing, but more importantly, in relevant to us here, thank you for honoring this invite to talk to us. I'm hoping to have you back here soon, because we continue with topics that are related to the area that you are an expert in. And to our audience, thank you, and wish you a great evening and a great weekend. See you next week. Bye.
All right, thank you.